So good afternoon. This is Rebecca Roper from the Agency for Healthcare Research and Quality Practice-Based Research Network. Thank you very much for joining us today on our national webinar. And we have actually 4 presenters. Our first presenter will be Dr. Wasson, who actually contacted me about reviewing a particular article. And we ended up chatting, and he was gracious enough with Dr. Norbert Goldfield to invite the PBRNs to have a special volume to speak about their experiences and research with respect to the use of health IT in practice-based research networks and having a broader spectrum of the types of studies that could be included in the special volume. And the PBRN community responded quite strongly with various snapshot, short, concise, compelling articulations of some iterative advancements that were being made, as well as full-blown studies, more conventional studies, which are reflected in the volume as well. So today we will hear from a few of the accepted authors, but again, this is a sampling of the types of activities that are occurring. Yes, we will have this national webinar available in integrated visual and oral presentation in a few weeks. But before that particular documentation is available on our website, for you who are participating, we will send you PDF files of the presentations today. So we'll have a brief overview of the JACM volume. Dr. Wasson will speak to that. And then we will have 3 substantive presentations by Dr. Chris Massi and Kenneth Anderson from the NorthShore PBRN. And we will also have Dr. Neda Ratanawongsa and her Sonja Likumahuwa, who are going to be presenting from Oregon. And we will have Christine Nelson. Excuse me, so it's Sonja who will be presenting with Christine Nelson from Oregon. And I'll give a slight introduction before each of them speaks. But in looking at their impressive resumes, what struck me was their individual devotion to understanding behavior of both patients, clinicians, and the organizations that work collectively as a team-based care to provide our primary care patients the best care possible. So after each presentation, we will have a 5-minute window to solicit some questions with which we will provide responses. And at the end of all the presentations, we'll have a little longer to go back and pursue and discuss some other issues that may have come up across the different presentations or for a particular presenter. And so Kristen will articulate how we will be encouraging you to submit your questions. Kristen?
Thanks, Rebecca. So I'll now explain how to submit a question to today's presenters. To submit a question, you may use the GoToWebinar control panel. Type a question under the questions section and hit send as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. During the Q&A sessions, as time allows, your questions will be read out loud and our presenters will respond. And if at any point during this webinar you have trouble hearing our presenters, please try hanging up the call and dialing back into the webinar. So Rebecca, I'll now turn the presentation back over to you.
Okay, just for ease of clarification, we're going to provide an overview and a snapshot of each of our presenters. So we'll first hear from Dr. John Wasson, who had the brainchild for this special volume. And then our next pair of presenters will be from the North Shore, Chicago, Dr. Chris Massi and Kenneth Anderson, who are going to talk about their technology-based quality innovation to identify undiagnosed hypertension among active primary care patients. This particular study was represented in the overview article of a mixed method that was conducted by Paula Littman and folks at the University of Minnesota, so this particular activity came to our attention. Since the publication of Paula Littman's article, this particular research study is actually underway and being identified and developed as an ARC Innovations exchange featured study. So we look forward to this particular study being featured elsewhere on the ARC website and disseminated further. And our next group will be represented by Dr. Neda Ratanawongsa, who is presenting also on diabetes, but how health information technology innovation to improve quality of life for plan members in an urban safety net. And our final presenters today will be Sonja and Christine Nelson from Oregon, who are going to talk about qualitative methods and user-centered design to develop customized health information technology tools with federally qualified health centers to keep children insured. And before I hand over to Dr. Wasson to speak about his journal and to encourage further PBRN submissions, it was rather nice to also see, once the volume came together over the fall and winter, and we summarized the particular dimensions of research that are represented, they actually match quite well with Dr. Kronik's vision of areas of interest for ARC going forward. So that was quite affirming for us, being engaged with what the PBRNs are studying and the relevancy of their findings to us all. Dr. Wasson, would you care to give an overview of your journal? And
Sure. Let me be very brief. First of all, it's great to be here. The Journal of Ambulatory Care Management has been around quite a while, and I became involved with it as a co-editor, I'd say almost a decade ago. And like all journals, this one faces the change or the challenge of how do you make a static journal become dynamic. And this opportunity came up to work with ARC and you all to begin to think of journals that have very rapid turnaround for you so that information becomes useful in the real world. So we've started a series we call Snapshots, and those of you who follow up with snapshots, let me use the jargon of the State Department, being that you'll get most favorable nation status. We'll look carefully at them. On this slide, basically, are the issues that snapshots should cover: patient engagement, if at all possible, patient involvement directly in the research. Can you go back to that previous slide, please? And also technology innovations. And if you look at the two journal articles that are available online for free at the site for Journal of Ambulatory Care Management, one will describe for you in greater detail how to submit an article, and the other, the second article on the slide, gives you an example of a snapshot. So we just want to make you aware of this as an opportunity for you to share your work. It doesn't have to be, a complete RCT or anything of that like. Much more favored are articles that say, look, we've tried this, here are our results. It's quick, it's innovative, it's exciting. Thanks very much. We're going to keep working on it. Next slide. One other opportunity I wanted to make you aware of, because we are emphasizing technology, is that many practice-based research networks and, of course, many providers don't have available to them technologies that can move them to the forefront of engaging patients, gathering information, etc. On the lower left-hand side are characteristics of a howsyourhealth.org technology that's been under development and used through many sites, and ARC has been supportive along the way, and is available to you for free at org. It provides you patient assessment tools, health action packages, patient resources, improvement system outputs, and most importantly, customization tools so that you can use them to develop research in real time while your patients are being served. So those are two things I wanted to make you aware of today. First, again, the journal request for what we call snapshots, and secondly, for those of you who feel you'd like to move and try technologies at absolutely no risk absolutely free, no advertising type technology called howsyourhealth.org. And that's it, Rebecca.
Thank you. Thank you very much. And with that, we'll go to our first substantive presenter, Dr. Massi.
Okay. So, thank you very much, Rebecca. Can everyone see this first slide?
Yes, it looks good.
I'm sorry, can you?
It looks great.
Oh, good, good. So, yes, thank you so much for inviting us to present our project. As you can see, this project is a collaboration among many individuals and many organizations. And just by way of background, for those who may not be familiar with NorthShore, we are a nonprofit integrated health system located primarily north of Chicago, and we have 4 hospitals, 80-plus clinics, 800-plus employed physicians, and probably 1,000 affiliated physicians. And one of the sort of strengths of NorthShore is we have been using a particular electronic health record for over 10 years, and we have developed rather strong infrastructure to support our electronic health record. So given the sort of depth of data that we have and access to the data, we have many opportunities to explore chronic diseases. And 2 to 3 years ago, we selected undiagnosed hypertension as a chronic condition that we felt we could address through the use of information technology. So just quickly, as I'm sure you're aware, hypertension is a prevalent chronic condition. It is also the leading modifiable risk factor for heart disease, stroke, congestive heart failure, and kidney failure. 1 in 14 U.S. adults has blood pressure greater than or equal to 140/90, but has never been informed they have hypertension. And hypertension is associated with very high costs related to both medical care and lost productivity. Variability in office blood pressure readings and physician mistrust of the accuracy of these readings contribute to the hesitancy of physicians to diagnose high blood pressure. 24-hour ambulatory blood pressure measurement is often recommended for diagnosing hypertension. However, ABPM can be cumbersome and is not well tolerated by many patients. Ambulatory office blood pressure, or AOBP, devices are simple to use, and five readings 1 minute apart have been shown to correlate well with daytime mean ambulatory blood pressure measurement readings. So this is just a photo of one type of a AOBP device. So the goals of this study were to apply computerized screening algorithms to the electronic health records of primary care patients in an integrated health system to identify those who may have undiagnosed hypertension. Then we wanted to evaluate these at-risk patients using an AOBP device in the clinic setting to make an accurate diagnosis. Our inclusion criteria were patients aged 18 to 79 who had received care within one of our network of 23 primary care practices in 2009 and 2010. Patients were excluded if they already had an EHR diagnosis of hypertension, pre-hypertension, white coat hypertension, or elevated blood pressure. So working with our sort of electronic health record support staff and data specialists, we developed 3 computerized hypertension screening algorithms and applied these to the electronic health records of the eligible patients. So these are the 3 algorithms that we came up with, and I won't go through them individually, but the goal of these 3 is to query our what we call electronic data warehouse, and that simply is the repository for all of the electronic health record data among NorthShore patients. So we really focused on the folks who met our inclusion criteria and who did not have a prior diagnosis of hypertension, and then we applied each of these screening criteria to their health records. And the gist of the criteria is to see whether they had some evidence of elevated blood pressure but did not have a diagnosis of hypertension. So you can see in the screening algorithms 1, 2, and 3, they really relate to elevated readings of blood pressure recorded in the electronic health record and then stored in the Enterprise Data Warehouse, or EDW. So those who met the screening criteria were then mailed a letter inviting them to make an appointment for a follow-up clinic visit. Up to 3 follow-up telephone calls were made if patients did not arrange this appointment. Once in the clinic, each patient completed the automatic office blood pressure screen using the BP True device. And this led to a mean blood pressure which averaged 5 readings which were obtained 1 minute apart. We then calculated the positive predictive values of the screening algorithms using the AOBP means. Individuals were diagnosed as being hypertensive if their mean AOBP reading was greater than or equal to 135 for systolic or greater than or equal to 85 for diastolic. Now these cutoffs were chosen because prior studies had shown that the AOBP mean blood pressure correlated very well with the daytime ambulatory blood pressure device. And it has been established that one should diagnose hypertension if an individual has systolic greater than or equal to 135 or diastolic greater than or equal to 85 using the ambulatory blood pressure measurement device. And then this just shows the formula we use for positive predictive value. So this is a flow diagram which indicated that among the primary care patients seen at NorthShore, 139,666 met the initial screening criteria, but then when we queried their EHRs, we found that over 47,000 had a prior diagnosis of hypertension, So that left over 91,000. And for these, we applied our 3 hypertension screening algorithms. And when we applied those 3 algorithms, we found 1,586 unique patients satisfied at least one algorithm. We then reviewed these patients with their primary care physicians as far as lists of patients, just to make sure that the primary care physician felt that the patient was appropriate to be approached. And in that process, the PCPs found 154 were not suitable to be approached for this study. That left 1,432 who were targeted for recruitment into the study and who were sent letters signed by their PCP. This slide simply shows the number of individuals who were identified using each of the algorithms. And you can see that each algorithm produced a different number of individuals who we deemed as being at risk for undiagnosed hypertension. Now, if you consider all 3 algorithms, that's where we found the 1,586 individuals. So when we invited people to come in for a AOBP screen, 475 of the 1,432 indeed did so within 6 months. And this table simply compares the 475 who completed an AOBP screen to the 975 who did not. And they really are very similar on all measures except for age. The people who had the AOBP screen were slightly older than those who did not. But the mean SBP, diastolic blood pressure, BMI, gender, ethnicity, proportion who have comorbidities such as gastroesophageal reflux disease, asthma, depression, etc., they were all similar. This slide shows the positive predictive values of our screening algorithms. So the first algorithm identified a certain number of people who are at risk. Of those, 234 came in to have an AOBP, and of those, 136 had an SBP of greater than or equal to 135 or a diastolic BP greater than or equal to 85. So we calculated a positive predictive value, and for algorithm 1 it was 58%. For algorithm 2 it was 52%, and for 3, 51%. And the bottom row simply shows that for all 475 individuals who came in for an AOBP screening, 249 met the cutoff for hypertension, and the positive predictive value for any algorithm was 52. This flow diagram shows the results of follow-up. So our initial phase covered 6 months of recruitment and clinic-based AOBP readings. But in addition to that, we also implemented a quality improvement program whereby our primary care docs received monthly notices regarding individuals who met the criteria by our screening algorithms for undiagnosed hypertension, and we let the primary care docs know how many hypertensive patients they were caring for and how many who were at risk for having hypertension who have not been diagnosed. So that occurred monthly. In addition, whenever a particular individual who had been identified as having, as meeting one of the algorithm's criteria, or one of the three, a notice arose in that physician's computer screen, electronic health record, indicating that patient was at risk for undiagnosed hypertension and suggesting that they should have that patient undergo an AOBP reading while they were in the clinic. So that was the phase 2 of our project, and that really is an ongoing quality improvement strategy which continues to utilize the power of information technology to identify individuals at risk and then prompt our primary care docs to conduct additional screening. So as we moved from months 7 through months 30, after the initial 6 months, 399 individuals were lost to follow-up for the shown reasons. And then we were able to follow over 1,000 patients, from the beginning of the study through 24 additional months, both phase 1 and phase 2. So over that time, 520 patients completed an AOBP, 411 in phase 1, 109 over the next 24 months. Overall, 246 people were diagnosed with hypertension. 185 were diagnosed with white coat hypertension, pre-hypertension, or elevated blood pressure, and 89 were classified as being not hypertensive. And over those 24 follow-up months, 513 of the 1,033 did not complete an AOBP protocol. However, despite not having that AOBP, we believe that through additional reminders and prompts, our primary care docs were able to make a diagnosis of hypertension in an additional 115 individuals, and then other diagnoses in 105 individuals. And then by the end of the 24 months of follow-up, 293 individuals really had not received any diagnosis. So in summary, 1,432 adults met the criteria of one or more of the screening algorithms and were recruited. Of these, 475 completed an office-based AOBP, and 249 were diagnosed with a hypertension. By the end of the 24-month follow-up, 72% of the original 1,432 patients had received a diagnosis, and you can see the diagnoses listed. There are some limitations. We believe the algorithms likely did not identify a significant number of individuals who are at risk for a hypertension, partly because the 3 algorithms were fairly strict. Less strict screening criteria would probably increase the sensitivity, but may decrease the specificity. The screening algorithms were based upon prior manual blood pressure readings, which may have been inaccurate. So we are currently in the process of really standardizing the way in which each primary care patient has their blood pressure obtained when they come into clinic. If we had conducted an AOBP reading on all at-risk patients, we may have found different positive predictive values, but we did note that the non-participants were similar to the participants. So as far as implications, our screening program relied on electronic health records, computerized screening algorithms, and a follow-up ambulatory office blood pressure measurement. And we expect, and we are seeing a trend for electronic health records and screening algorithms to be increasingly used to diagnose chronic disease. So I just discussed an example of picking up undiagnosed hypertension, but a BMP or basic metabolic panel can be used as an initial screening test for diabetes or chronic kidney disease. A CMP or comprehensive metabolic panel in the electronic health record can be queried, and given certain cutoffs, individuals can be identified who may be at risk for a hepatitis or fatty liver disease. Similarly, a complete blood count or CBC screening program can be used to find individuals who are anemic but may not carry the diagnosis of anemia. And then using a particular diagnosis, such as history of syncope, can help identify individuals who have arrhythmia or who may be overtreated for hypertension. So that's my last slide, and I will turn it back over to you, Rebecca.
Great. Thank you very much, Chris, for that very comprehensive presentation. In the interest of time, I'll hold off asking questions until after the other presenters, but might want to plan to out if you can, at the end of the presentations, extrapolate a wee bit more on NorthShore's the mini fellowship program and other quality improvement activities as they were integrated into the overall PBRN activities at large. You mentioned the monthly quality improvement outreach, but as we have time, perhaps you could speak more about some of the other quality improvement contextually relevant activities.
Yeah.
Thank you. And so next, we will hear from Neda, Ratanawongsa, who's going to present on their particular project. She is Chief Medical Informatics Officer for CareLink San Francisco at the San Francisco Health Network. Her research focuses on research, teaching, administrative, and clinical work on enhancing communication and therapeutic alliances between patients and providers in safety healthcare settings. Thank you.
Great, thank you very much. Can folks hear me okay?
Coming through loud and clear.
Great. So thank you so much to AHRQ for this opportunity, as well as to the Journal for a place to present our work. I have no conflicts of interest to disclose. Before I describe our project, I wanted to first describe our group and the communities with whom we work. We're practice-based researchers in the Community Health Network of San Francisco, which is the Public Health Department's integrated healthcare delivery system. The stakeholders for our work include persons with diabetes and their primary care clinicians and teams, as well as the health plan coordinating and managing their care. And we think these are representative of larger of the rest of California, which is comprised of many diverse stakeholders. And our work has evolved from studying health disparities to developing practice-based interventions, and now to partnering with a health plan to try to attempt more population-based implementation. So for today's discussion, I'm going to review existing disparities in diabetes, health, and healthcare related to communication barriers in traditional healthcare, describe how we scaled up a diabetes self-management health IT intervention as a covered plan benefit in San Francisco, review the outcomes of the intervention, and then discuss what we learned in our next steps. So one of the main motivations of the work that Dr. Schillinger, our PI, has done is motivated by his interest in health literacy. And over half of our patient population has limited health literacy in our public hospitals. Numerous studies have documented the association, the association of limited health literacy with poor health knowledge, worse self-care, and higher utilization, as well as worse health outcomes, including glycemic control in diabetes. Inadequate functional health literacy is also associated with poor experiences of communication with clinicians. Patients with limited health literacy are more likely to report that doctors use words they don't understand and give test results without explanation. And also, they report a higher odds of feeling confused about their medical care and feeling like their physicians don't understand the problems that they're having carrying out their treatment. And similar disparities exist in the healthcare experiences and health outcomes of patients with limited English proficiency. Patients report that they have unasked questions about their care and are not receiving self-management advice. And patients with limited English proficiency who lack a language concordant provider have been shown to have poorer control of their diabetes. So health information technology offers several strategies that may allow for us to expand self-management support for patients with limited health literacy and limited English proficiency. In particular, automated telephone self-management, or what I'll call ATSM in this presentation. This offers the promise for a health IT strategy that may have a broad reach in places like California and across the country where many people have a telephone, and you have the ability to control the messages and craft them in ways that are tailored to literacy, language, and culture. The first program that was started by our group was the IDEAL program, which is called Improving Diabetes Efforts Across Language and Literacy. This was developed with users in their preferred languages, in this case English, Spanish, and Cantonese. And the ATSM system provides weekly calls with rotating queries about self-care, such as diet, exercise, and medication adherence, psychosocial issues, such as depression symptoms, and access to preventive services, such as eye care. Patients receive a call and then get asked a question about these topics, and they respond by typing in their response on the phone. Based on their answers, they hear automated health messages in their own language in the form of narratives. So for example, if they said that they had trouble taking their medication 3 out of the last 7 days, then they would hear a story about Ms. Cho, who also had some difficulties, and the strategies that she used to remember her medicines. If a patient answers out of range on a pre-specified sort of set of answers, then they get a callback from a language concordant care manager within 3 days. And the care managers provide education and engage in collaborative goal setting to form patient-centered action plans. And finally, the care managers would notify primary care providers regarding any concerning safety or access issues. The system was developed iteratively in conjunction with stakeholders, first from clinicians in identifying the populations that need, and then with patient stakeholders to develop culturally concordant and engaging narratives about self-care behaviors that were important to patients. So the original randomized control trial for IDEAL was done a few years ago, and it was a 3-arm study comparing ATSM with group visits and usual care at 4 clinics. 84% of patients receiving ATSM actually formed at least one action plan during the course of the trial. And primary care providers reported high satisfaction with the strategy, perceiving that patients were more activated and received higher quality of care. The outcomes associated with ATSM included improved communication with their providers, more self-management behaviors such as diet and exercise, improved functional status and fewer days confined to bed, as well as the detection of adverse and potentially adverse safety events. And it was also found to be cost-effective as well. So then this project that I'm going to describe today really took this to a different partnership by working with our local government-sponsored Medicaid plan to see if we could improve coordination of care and support patients and clinicians and use health IT to reduce disparities for health plan members. And this was targeted because a survey of California Medicaid managed plans showed that few had chronic care management targeting these populations. 68% had planned to expand programs for diabetes. But they all reported experiencing cost barriers, including the cost of broad implementation and challenges with health IT. And so we partnered with the San Francisco Health Plan, which is a nonprofit government-sponsored managed care plan that was created to provide high-quality medical care to low-income San Francisco residents. Together, we developed the Smart Steps program, which stands for Self-Management, Automated, and Real-Time Telephonic Support. Smart Steps offered ATSM as a covered benefit for English, Spanish, and Cantonese-speaking health plan members with diabetes who were receiving care from 4 community clinics. And those clinics are part of the San Francisco Bay Area Collaborative Research Network, which is UCSF's primary care PBRN. The health plan conducted all recruitment and also conducted the self-management coaching, and UCSF conducted the evaluation of the program. We chose a quasi-experimental study design, which was called a waitlist variant of a step wedge design. And the idea is that the health plan randomized its members to waitlist or immediate intervention during 4 recruitment waves. Waitlist participants crossed over to intervention after 6 months. And this design allowed for a controlled evaluation so that we could still compare waitlist with immediate intervention members, but it also ensured that all health plan members who wanted to be participating in ATSM were able to do so, which was an important goal for the health plan. It also allowed for less intensive implementation staffing because it limited the number of members actively receiving ATSM at any given time. And then, as with the ideal study, the intervention involved ATSM with callbacks. But in this situation, the health plan decided to use a lay health coach model for callbacks rather than a nurse practitioner. And the health plan and UCSF designed tailored training for the health coaches to teach them about diabetes, patient-centered behavior change counseling, and action planning. We provided detailed scripts with probes to support coaches in their calls and helped give them feedback and role play. The next slides will describe the outcomes, and I'm going to focus on levels of engagement with ATSM as measured by the % of completed calls. And then I'm going to describe the comparison between intervention and waitlist in the change over 6 months in diabetes self-care, quality of life, and cardiometabolic markers. So this is our consort flow diagram for the study enrollment. Among the 362 randomized health plan members, 70% of participants completed both a baseline and a 6-month follow-up evaluation interview and are included in the analysis today. This table describes our participants, and they did not differ between intervention and waitlist groups. They averaged about 55 years in age, and over 70% were women. A quarter were Latino, and 60% were Asian. And it's typical for our population, 85% were born outside of the U.S. Just over half spoke Cantonese, and 20% spoke Spanish. Fewer than half had been educated past 8th grade, and about half had limited health literacy on a validated screening instrument. 2/3 earned less than $20,000 a year. And in terms of diabetes control, a quarter to 30% had A1Cs of greater than 8%. This figure shows completed calls among those who were exposed to all weeks of ATSM. I apologize for this. The engagement remained high throughout the 27 weeks of calls, particularly for Cantonese speakers, as you see here in green. And this graph also confirms that what we see in the, this table confirms what we see in the graph, which is that there was a difference by language in engagement with higher numbers of completed calls for our Cantonese speakers, a median of 21 over the 27 weeks, compared with our Spanish and our English speakers. Finally, the next slides show our 6-month changes in our 3 main outcomes, comparing the intervention to control groups. As you can see here, the intervention was associated with overall improvements in self-care, as well as specifically within glucose monitoring and foot care. Self-reported medication adherence did not differ. And then using the SF-12 to measure quality of life, you see that we had a significant standardized effect size in the physical component score. There were no significant differences in mental component of SF-12. And then finally, with looking at change in cardiometabolic markers in A1C, blood pressure, and LDL, we did not see changes from baseline to 6 months in the outcomes related to cardiometabolic control. So overall, I would say that we concluded that ATSM with a lay health coaching model, as implemented by health plans, may offer a scalable strategy for health plans and health systems aiming to enhance chronic disease outcomes at a population level. The study harnessed partnerships among a government-sponsored health plan, a safety net integrated healthcare system, and practice-based implementation researchers, and allowed us to translate a self-management support intervention from an RCT into a practical implementation for this population. Like the earlier randomized trial, it supports the benefits of partnering with patient stakeholders to develop a linguistically and culturally concordant health IT intervention. And the work suggests it's possible to engage in practice-based research within under-resourced safety net systems, particularly partnering with a health plan that's committed to improving care for its diverse population. issues to consider as you go forward are the challenges of phone-based population recruitment, which could result in selection bias. Health plan experienced a lot of turnover in health coaches, which can affect the fidelity of the intervention as well as data collection. And it's important to consider whether your coaches are not only bilingual but also bicultural, which was true for our Cantonese health coaches and may have affected the sort of level of engagement and the outcomes for that population. The study does lend support to using a quasi-experimental study design in this kind of work as well. And I'll conclude by just saying that our team is partnering with others to expand the scope of ATSM into other content areas, such as gestational diabetes and chronic kidney disease, looking at other platforms beyond telephones, and figuring out ways to link the health IT back into the health records of the patient-centered medical homes to have a more integrated approach, and figuring out ways to sustain this long-term in our health system and in partnership with our Medicaid programs. But we're excited about the promise of these programs, given their potential to engage patients, to promote self-care, and to improve quality of life in a diverse safety net population. I want to thank our PI, Dr. Schillinger, as well as the collaborators listed here. And I'm happy to take questions if we have time. Thank you.
Great, thank you very much. Earlier today, I sent out a notice that ARC has a new RFA with respect to how to use telemedicine in primary care in bringing forth PCOR findings, so that might be of interest to the presenter as well as many people on the call. Also, the presenter's study brings to mind that there are folks at ARC who are working with the American Board of Pediatrics to develop a Part 2 and Part 4 maintenance of certification module for health literacy. And once that's available, we will certainly tell our PBR memberships about that. And let's see if we have any particular questions for Neda. You talked, Neda, about the variation by the importance of bicultural competency, and you actually have 3 cultures being engaged. Were there some technical challenges in being sensitive to cultural variation in the programming of this intervention?
Well, I think the programming of the narratives, this was done very carefully years ago with focus groups and stakeholders, and ongoing work continues to use focus groups to really develop, for example, gestational diabetes messages that are not only in Spanish, but attentive to food, exercise, lifestyle, family, other things of importance. I think the trick is that it's 3 languages, but many cultures. There's definitely not one monolithic Latino population here. We have a little more uniformity, perhaps, with Cantonese speakers in terms of some background, but and then, of course, among English speakers, it's a diverse group. And so thinking through how health coaches bring forth their own sort of culture and expectations and experiences into their interactions with patients, we think that there was some benefit in our health coaches who were from the community that they were calling, and San Francisco Health Plan has wonderful sort of staff who are from San Francisco and can engage in the community, whereas our Spanish-speaking health coaches were not all Latino, and we think that that can influence sort of the engagement and sort of the interactions in terms of forming health action plans that way. So it's just something to think about as we go forward, and I know our gestational diabetes project is working with health coaches that both self-identify as being Spanish-speaking fluent and also bicultural.
For that very comprehensive response, and we will keep you on the line if we may, and hopefully ask you some questions after the final presentation.
Great, thank you.
So our 3rd presentation will be from the Oregon and Health Sciences University folks. So we will have Sonja Likumahuwa and Christine Nelson, who have diverse histories, strong histories with the OCHIN Practice-Based Research Network. And I will turn it over to them in the interest of time.
Thank you for that kind introduction. This is Christine Nelson. I want to make sure before I go further that everyone can hear me.
Yes, Oregon's coming through clearly.
Well, it's a pleasure to be invited to present our study, which we refer to as IMPACT, The long name is the Innovative Methods for Parents and Clinics to Create Tools for Kids Care. The purpose of this study is to develop and test new health information technology tools, which I'll refer to from now on as HIT tools, to enhance insurance outreach efforts. This impact project is led by Dr. Jen DeVoe and funded by PCORI. It is an ongoing project that is engaging families, clinic staff, and medical informaticists to design tools for health insurance outreach. Our presentation today focuses on the first phase of the multi-year, multi-stage project that involves qualitative data collection in the participating federally qualified health centers, or FQHCs. To provide some background information, it won't come as a surprise that stable health insurance facilitates access to health care for children, and that coverage gaps are associated with unmet health care needs and poor health care outcomes. Despite federal initiatives to increase coverage, millions of U.S. children remain uninsured or experience frequent gaps, although there may be changes in the numbers of uninsured based on the implementation of the Affordable Care Act. Notwithstanding, patients on public health insurance must regularly reapply to maintain coverage, and even when patients receive alerts telling them when their resubmission forms are due, coverage gaps persist. Primary care patients and the practices that serve them benefit when insurance gaps are minimized and patients remain consistently insured. But before I outline the specifics of our study, I'd like to introduce OCHIN, the organization at which this study is being conducted. In 2001, a group of Oregon FQHCs partnered to form a member-based nonprofit collaborative called the Oregon Community Health Information Network, and renamed to the acronym OCHIN as other states across the nation joined. OCHIN is a HRSA-designated health center controlled network with the purpose of supporting state-of-the-art HIT infrastructure and facilitate implementation of electronic health records in safety net clinics. OCHIN also supports a practice-based research network. As of April 1st, the OCHIN PBRN had members in 17 states with more than 300 primary care clinics and more than 2,500 providers caring for more than 1.5 million patients. Most clinics in the PBRN are FQHCs that care for low-income families with a preponderance of women and children among their patient populations. All member clinics in the OCHIN network share a common HIT infrastructure and an Epicare Systems electronic health record. Patient data are retained in a single centrally hosted EHR database. Our work is an extension of the program of health services research that has been undertaken by Dr. DeVoe, the lead author on this paper. She is examining the impact of health insurance on access to and outcomes of care. This project was based on some of her previous research showing that there were gaps in children's insurance and considerable churning on and off insurance. This slide presents the EHR data that were collected from the OCHIN network retrospectively, looking at a cohort of all children ages birth to 18 years who visited an OCHIN site during a 2-year study period. We obtained EHR data on patient insurance status from visits occurring during the study period, which provided us with an understanding of the need to support insurance enrollment and retention. The large pie chart on the left shows the insurance status of children at the beginning of the study. At their first visit, notably, almost a quarter of the children were uninsured, making them ideal candidates for a system to identify and enroll children in health insurance. 67% were already enrolled in Medicaid, and 12% had commercial insurance. The smaller pie charts on the right show what happened with these groups over the course of the study period. Of the children with no insurance at their first visit, the top right-hand chart, a substantial 30% remained uninsured throughout the 2-year study period. This is obviously a group that would benefit from insurance enrollment programs. And 19% gained Medicaid for at least one subsequent visit. Of the children with Medicaid at their first visit, the central pie chart on the right, 72% remained insured, which is a group that obviously would benefit from re-enrollment support throughout their tenure with the FQHC. Finally, of the children with commercial insurance, the lowest right-hand pie chart, 53% had insurance at every subsequent visit. Note that for the groups that initially had insurance, either Medicaid or private insurance, 4 to 5% were uninsured at a subsequent visit, which provides evidence of the churning effect on and off insurance that we're hoping to prevent. As an initial step in our study development, we recruited 8 Oregon FQHCs to participate in this study with selection based on the population they served, a population with high pediatric uninsurance rates and large pediatric panels. The initial phase of the study, which we're reporting on today, involved qualitative data collection in the participating FQHCs. I'm now going to turn the presentation over to my colleague, Sonja Likumahuwa, who was instrumental in the conduct and analysis of the qualitative data collection phase of the study.
Thanks, Chris. We had 2 key questions that we sought to answer through qualitative data in the impact study. The first is, how can patients' families, medical informaticists, and FQHC staff be engaged in the development of HIT tools to support health insurance outreach? And second, how can HIT resources be used within the FQHC setting to reach uninsured children and those at risk for losing coverage? During the first 6 months of the project, which as Chris mentioned began last year in 2013, we collected qualitative data from the study sites. The study team spent approximately 95 hours directly observing at 4 clinic sites and conducted one-on-one interviews with 19 families and 31 FQHC staff members representing many different roles at the clinic. Reflecting the patient population at our study sites, more than half of the family interviews were conducted in Spanish using an interpreter. During the site visits, we observed routine tasks specific to managing insurance gaps, and we talked with staff about points in the clinical workflows at which the EHR could be customized to improve how those insurance outreach tasks are accomplished. We learned that multiple strategies and workarounds are already being used to conduct health insurance outreach. These include tracking insurance information in Microsoft Excel workbooks, monthly review of paper insurance applications to follow up on whether the applications were approved or denied, and scrubbing patient charts for insurance information prior to their visits. Clinicians are not currently involved in insurance outreach tasks. The key staff that are involved are front desk, insurance enrollment specialists, schedulers, social workers, community health workers, and care managers. Clinics are utilizing chronic disease management tools such as registries, reports, and EHR flags. These same types of tools may be able to be used for insurance management and outreach in the clinic. During our staff interviews, we learned that staff feel that insurance is a high priority issue and that they view the current strategies and workflows that I described earlier as inadequate and inefficient. FQHC management did not want providers or medical assistants to be involved in the potential HIT tools that the study is developing. And notably, staff wanted to be sure that the tools that we develop during the study will function within the context of changing health policy, such as the health insurance exchanges, Medicaid program expansion, and coordinated care organizations, which now manage Medicaid patients in Oregon. During our family interviews with caregivers of publicly insured children, we learned that families highly valued health insurance. However, these families face challenges when trying to maintain and track insurance, including needing to track different coverage end dates for different children in the family, reapplication letters sent to old addresses, the volume of paperwork, and language and literacy barriers to understanding the forms. Families want and need clinics to assist them with insurance enrollment, and we're comfortable with clinics keeping track of insurance information for their children, such as coverage start and end dates. Families were comfortable with telephone calls, text messages, letters, email, and personal health record communication strategies, as long as they were conducted in a culturally competent way. I realize that this text is far too small for you to read, but I've included an example of the type of workflow diagram that we developed using Microsoft Visio. Using the qualitative data that we collected, we diagrammed the current clinical workflows around insurance, including FQHC staff use of the EHR and other HIT tools in insurance-related tasks. We also included stakeholders' design ideas that came up during our interviews. These workflow diagrams were a very effective way to communicate what we learned during the qualitative data collection process about FQHC processes and needs back to the OCHIN tool developers who are actually programming the EHR tools. We iterated ideas many times with key stakeholders, including patients, clinic management, and the end users representing different clinical staff roles. Through this process, we identified a need for a customized suite of insurance outreach HIT tools that can be integrated into clinic workflows in several different ways. The proposed suite of tools will pull together data from various parts of the EHR, including demographic, visit, and insurance coverage data. The data support HIT tools designed to catch patients at two types of touch points. First, as they interact with the clinic to schedule or attend a clinic visit, what we've called in-clinic tools. And second, when patients are between visits and not initiating contact with the clinic, what we've called beyond clinic tools. The in-clinic tools will include tools for pre-visit scrubbing for insurance, pop-up information about insurance during scheduling, alerts for the front desk at the time of check-in, and automated information in the after-visit summary. Beyond clinic tools are used for outreach and include strategies such as automated calls in the patient's preferred language, automated notification via text message or postcard, personal calls from the insurance outreach coordinator, and messages through the patient portal. All of these strategies are intended to allow clinic staff to easily refer patients to the insurance outreach coordinator at the clinic for assistance with insurance applications, and to direct families to information and resources about insurance. In conclusion, the first phase of the Impact Kids Care project illustrates how qualitative methods are part of a user-centered design approach. We've identified ways that health information technology can be used to identify, track, and communicate with families about their child's health insurance coverage. The project has developed strong partnerships between families, clinic staff, and medical informaticists to develop HIT tools that are relevant for the clinic. We feel that the methods that we're using may be applied to other HIT needs in primary care settings. I'd like to acknowledge the study's funder, PCORI, and the other authors on this research paper, and I'm open to taking your questions. Thank you.
Great, thank you very much. Feel free, if someone is out there would like to post a question. Could you please elaborate whether you thought because of the variety of stakeholders involved, there were any particular issues because the insurance gap that was sought to address was for children? Were there some unique lessons because of that target audience?
An interesting question. We chose to focus on children as part of this study in part because of the amount of prior research that our study team had conducted around children's health insurance and what happens, as Chris earlier described, when kids are turning off and on insurance. I think that across the board, the clinical staff and all of the key stakeholders that we worked with really recognized the value of focusing on children first as a logical sort of initial step in trying to help people track and maintain health insurance, in part because kids are coming into the clinic so frequently, and there's a high priority placed on helping to serve the needs of the families with kids to ensure that they're getting the appropriate care that they are entitled to.
Okay, thank you. Is there anything that you learned through this process that you wish someone would have, or you would have had advanced knowledge as far as something that maybe could have gone a little smoother, that you only experienced through the conduct of the study?
Mm-hmm. Well, the study is ongoing, and I think that probably the biggest lesson learned has been the process of trying to translate qualitative data to computer programmers. It's two groups of people who speak pretty different languages and have fairly different cultures. And I think that when we stumbled upon the use of the workflow diagram as the primary communication tool to translate what we learned during our qualitative data collection into sort of a language and a format that IT tool developers could understand, that's when we started to really make progress on drafting some potential tools. I think that was probably one of the biggest challenges that we've faced. But it's been terrific for me as a qualitative researcher to work with this project because it's a very tangible product that's coming out of the work, and it's been very rewarding to work with our stakeholder partners.
Great, thank you.
I might also add another challenge has been that one of the key pieces of information that helps drive this system is knowing what the public insurance start and end dates are. And although we anticipated that it might be challenging to get those dates from the state, it actually has been far more difficult than we had anticipated and more time-consuming. And I'm happy to report that we have had success, and the state will be providing us with those dates, but it's taken almost the first year of our study development in order to achieve that end.
Well, congratulations, and thank you for your perseverance on that. That's fabulous. We do have a question from one of our listeners who's very interested in your patient survey that you used and was wondering, might you be willing to share that, or it may be available at some point?
The patient survey that I think the person asking the question is referring to was very tailored to this particular study, so it wasn't a general one. It was a semi-structured interview questionnaire that asked about patients. Well, it was not actually, we didn't interact directly with the pediatric patients, but rather with their primary caregiver. So it asked about their experience with health insurance and some of the barriers and challenges that they have faced and their experience with the clinic. I think it's definitely possible to share that semi-structured interview questionnaire, and we would be happy to do so.
Oh, thank you so much. So if anyone else has a question for any of the panelists, you please use the question posting option. And while we wait for others to formulate questions, if all the panelists can make themselves available, and Dr. Massi, if maybe you could chat a little bit more about NorthShore's mini fellowship program with respect to quality improvement at large.
Oh yes, certainly. Thanks for asking. So our health system is, as I mentioned, a not-for-profit integrated health system, and we are affiliated with an academic medical center, the University of Chicago, but we are not ourselves an academic medical center. Nevertheless, we have developed a sort of mini fellowship in quality improvement, and we are now in our 4th year of that. And we have junior sort of clinicians who the vast majority of our, or a large number of the NorthShore clinicians do have academic appointments at the University of Chicago. And many of these folks are very interested in quality improvement. And this fellowship was started by Dr. Ken Anderson, who's a co-author on this paper, and Dr. Gautam Rao, who is a family medicine physician. And the mini fellowship consists of lectures and seminars and meetings every other week for 7 months. And the lectures and seminars cover a lot of topics that are important to quality improvement. And in addition, each quality fellow is expected to conduct a quality improvement project. So the first author on the study I presented is a family medicine physician who, really wanted to address the issue of undiagnosed hypertension, and began working with our informatics experts, and over time it really recruited a variety of individuals to help him. And the bottom line is the study presented really did start as a quality improvement practicum that was part of this fellowship. So we are in the midst of our 4th year of this fellowship. Every year we have 7 or so fellows, and each fellow conducts a project similar to this, and oftentimes it does really try to harness the HIT resources that we have here at NorthShore.
Fabulous. Thank you very much. Let's see. So with respect to the telephone options, one of the commenters is saying that they're from a rural state, have landline telephones. Since cell phones are dominant, could the protocols that use phones substitute text? Do you have a mentor suggestion for the use of current media?
So this is Neda. Is that related to, are you thinking related to my project then?
I would think so. They didn't specify, but I think you're a good start.
Okay. So I think, yes, I think the idea that particularly in many areas people are no longer using landlines, I think the idea of actually, well, meeting people where they're at with their preferred technology, whether it's their cell phone text, the logging onto a website through a portal or other technologies, I think is very important, and lots of great research is being done in many different health systems about those. I think the our phone system could call to a telephone, whether it's a landline or to a cell phone, so it doesn't preclude using the same automated telephone system. But certainly, I think thinking through ways of programming apps or other ways of having people be able to answer on their device that they're most comfortable with would be next directions, assuming that you can get the security set up to be able to convey the information in a secure way.
Wonderful. Will each of the presenters, have you thought about something else, a little pearl of wisdom you'd like to leave us with? Christine Nelson?
I think one of the wonderful opportunities we've had is for this multidisciplinary collaboration that Sonja referred to when she was answering her first question. It's been a real joy to work with the developers of the EHR content and then to take the information that we're developing in the beta test format of the tools back out into the clinics to get their suggestions and refinements. And the collaborative process, not only within OCHIN for all of us working directly with the EHR, but then with the FQHCs that are going to be utilizing these tools, has been rich and something I would encourage all researchers to find a way to do. It feels like we're really being able to ground our efforts in what works and is relevant for the people who are actually interacting with patients in the real world.
Great, thank you. Chris, was there anything else you'd like to leave us with?
So I would just really emphasize this notion of harnessing HIT, which obviously is the theme of this webinar. NorthShore is fortunate in having a robust HIT infrastructure as well as 10 years worth of electronic health record data in a enterprise data warehouse which we can query. And the project we presented really focused on one disease process, but as we all become more and more interested in outcomes and in quality of care, it really is such a benefit for us and for others to be able to query our data warehouse and identify sort of measures of quality. We may not have access to all of the actual outcomes, but intermediate measures such as hemoglobin A1C for diabetes, different cholesterol levels for a heart disease or a high cholesterol, etc. IT permits access to that and then permits really, I think, pretty sophisticated evaluation of quality. So we are currently using our access to this information to closely monitor quality of care provided to diabetic patients and really identify best practices and identify those physicians who, even after adjusting for the severity of their patient's illness, seem to provide the highest quality care. So that leads us to something that we discussed earlier in this webinar, which is taking data from IT and then moving on to qualitative work. And so we're in the midst of interviewing these really high performers to get a sense for how they're able to provide such high quality care. And we would not be able to identify them if we did not have access to the data. So I just really thank everyone for hosting this webinar and placing such an emphasis on IT, because it truly is a very powerful tool in healthcare.
Great, thank you very much. And so as I said at the beginning, we had a very strong response to this special volume. And actually some of the PBRN papers, some came out in the earlier volume of the Journal of Ambulatory Care Management, and others will be seen in subsequent volumes. So while we so appreciate the special call, please keep your ideas coming to the Journal of Ambulatory Care Management. As Dr. Wasson spoke about, they have preferences for the snapshot presentation of compelling and innovative findings, which I hope will be a liberating format for folks to provide their insights. and we look forward to other national webinars that we can hold downstream. And Kristen's going to take a moment to tell you how you can earn CME credit for participating in this particular webinar, and then I'll put a plug in for some future activities.
Thanks, Rebecca. And thank you, everyone, for attending today's PBRN webinar. This live activity, Harnessing Health Information Technology to Assist Individuals and Teens, has been reviewed and is acceptable for up to 1.25 elective credits by the American Academy of Family Physicians. To obtain CME credit for your participation in this webinar, please complete the online evaluation of this webinar. You'll be prompted to do this when you exit the webinar today. And then please email pbrn@abtassoc.com if you would like to request a copy of your CME Certificate of Participation. Next slide. So we are currently planning for and scheduling additional webinars on these topics of interest. If you would like to present on one of these topics, or if you would like to suggest an additional webinar topic, either for July or some other time in the future, please send your feedback to pbrn@aptassoc.com. And you can also visit the PBRN website at pbrn.arc.gov for more information on PBRN webinars and events. And
in addition to identifying yourself as a potential presenter, if there is a particular PBRN that's working in one of these areas, especially patient engagement and contemporary issues and economic analysis, and you'd like to let us know about them so we could reach out to them and see if they would be willing to present, we welcome that type of reference collection as well.
Great point. Thanks, Rebecca. So we can go to the next slide, and Rebecca, I'll turn it back over to you.
So another reference that you might want to keep on hand is my colleagues in the Patient Center Medical Home Resource Center have developed over 12 guidance documents with respect to conducting evaluations in patient-centered medical home. Some of those particular strategies are reflected in the papers in this Journal of the There are also 5 national webinars at this website that Kristen has put up for you. If you have interest in certain types of methodological strategies, it's an excellent resource. If you have ongoing tutorials and education and retraining about members in your PBRN, you might want to take a look at it to see if it's a course for training for new methodologists or primary care clinicians who are more active in articulating their research study ideas and pursuing research with your PBRNs. And so again, I thank everyone who was so responsive to the call to the Journal of Ambulatory Care Management for the PBRNs and how to harness health IT in practical ways, that these particular presenters have provided their firsthand experiences. And since it's Dr. Wasson's, he's the editor for this journal, I will let him give the final word. I will note, though, before I turn it over to him, that we've been watching the membership to the PBRN grow. We're now at about 1,050 people, so it's accrued about 300 folks in the last year and a half, which is lovely. And if there are others who are members of your PBRN or have interest in primary care organized research, feel free to contact us and join our conversation. And Dr. Wasson, with that, we'll let you have the last word.
I think Dr. Wasson actually may unfortunately have had to sign off early.
Well, that's all right. I'll have the last word by saying thank you, and do keep the ideas coming for what you want to hear about to this forum, and also what you want to speak about. And I hope everyone endures what might be a very nasty period of time weather-wise and is able to keep dry and healthy. And I thank the presenters very much for their time and their commitment to this process. Thank you.